Hey, it's showtime. Well, hello, Miss Stacey. How are you?
Good. I was wondering what was going to come out there.
Yeah, I was going to throw some really big pejorative, but I decided not to. I thought you'd Miss Pain in the Buttinsky or something like that. Yeah, yeah. But anyway,
Own it.
own it. Yeah,
What
you
I
do.
do.
It's good. Yeah.
Yes.
Um, all right. Well, why don't you tell everyone a little bit about what we do and our fun special interest group that we have?
Absolutely. So, this particular evening is brought to you by OCD and SUD,
Dun,
substance
dun,
use
dun,
disorder.
dun. Oh,
Yeah.
sorry.
Um, for those individuals in our community that are living with both OCD and have a substance use disorder, we talk about that and answer questions related to both disorders. And I give a little bit of my own experience since I'm in recovery from both of them. And we have a website that is ocdsud.com. And on that website, we have various videos, PowerPoint presentations that we've done at conferences for the International OCD Foundation. There's some great short videos of you, Patrick, talking about addiction.
Me? Wow. I
Yeah,
didn't.
you. Yeah. So,
It is
and
true.
there's
It is true.
links to other videos that we have done on this YouTube channel.
Awesome. And tonight's broadcast also brought to you by NoCD, an online platform for the treatment of obsessive compulsive and related conditions. If you're looking for help for OCD, go to nocd.com. We have people standing by waiting to meet with you. We would be happy to chat. Again, nocd.com. All right. Well, Caden says, whenever it starts off this way, I'm just going to say yes before I even read anything. Do you want to guess what it might start off with, Stacey?
I don't know. With you, it could be more than one thing.
That's true. It's can OCD cause?
Yes.
Yeah. There you go.
Yes.
So there you go. Yes. Yes is the answer. Sure. So I don't even know if we need to answer. I guess we will read the rest of the question. But can OCD cause feelings of attraction to be something you normally would not ever be attracted to before OCD took hold? Yeah, of course. Yes. That is exactly what it is. If you have issues about feeling attracted to things and then you hope not to feel attracted to them, and then you think about the attraction and then hope that you won't feel the attraction when you are confronted with something, that's kind of the pink elephant effect of the moment you hope not to think of a pink elephant, you're going to think of a pink elephant. Or if Stacey and I started talking about pink elephants and then said, oh, by the way, in our discussion of them, please don't think of them, that would be rather impossible.
Yes. And now I have visions of pink elephants, but my pink elephants have pink little wings too.
Oh,
And
do
they're
they?
flying
Oh,
around the
they're
room.
flying pink elephants. Oh.
Yes.
Mm-hmm.
But yeah, OCD will attack whatever is important to you.
Yeah.
So, if it's something that is important to you or something you don't want to have,
Yep.
that's what's going to head.
That's what it's going to go. Yeah. So if you really like something, OCD is going to get you to doubt it. And if you don't want to think of something, OCD is going to go right there. Right.
Yep.
So let's see.
Any advice on the compulsion to try and solve OCD?
Take that one. Why don't you? Because boy, you with your lived experience, I think that's where you're going to.
Well, I tried for years and years and years and years and years to solve it. Problem is, you can't satisfy OCD. There is no answer that OCD accepts. You get an answer, you do a compulsion, you do what it asks you to, and it says, are you sure?
Yeah.
Let's do one more.
Mm-hmm. Yeah. Kazanish says, thank you for all that you do. Wonderful. We've helped a lot. You spent 4 months without compulsions after challenging things. OCD is back, but you're still a work in progress. Well, aren't we always a work in progress, Stacey?
Yes. And I want to make a comment about OCD being back. I mean, it
never
that's one of the big things is what defines recovery. because people feel like if they have an obsessive thought that maybe they've taken a step back or relapsed. Thoughts are thoughts.
Nope.
Same with substance use disorder. We get I'm having a brain cramp here. Stress hormones like cortisol is one example, and they can increase the potential obsessions and or compulsions, and they can also increase cravings for substances. So when you are stressed, you can have more cravings for whatever your substance of choice is, whether it's, alcohol, marijuana, cocaine, it doesn't matter. Your stress level goes up, your cravings go up. But it's not so much the craving that's the problem, just like it's not the thought that's the problem. It's how you respond to the craving or the thought.
Yeah. Bruce talks about habituation, and hard time waiting for habituation. And I will say, while habituation will occur for the vast majority of people, it won't always happen, right? Not everybody habituates. And what do we mean by that? That sometimes people stay anxious or uncomfortable about something for the rest of their life and it doesn't decrease. And you know what? That can still be a success in treatment because you've learned that, and you've learned that even though it feels that way, you can still handle it. So while the vast majority of people might habituate, it isn't a guarantee, which is something that we call on now that we look at called inhibitory learning. This idea that I learn a new way to respond to OCD. Instead of doing compulsions, I do the opposite. I do response prevention. And in inhibitory learning, the response prevention that I practice starts to inhibit the recall of the old way of doing something or the compulsion. And back in the old days, and Stacey, we're old, so we know the old days of this, we would have thought somebody who didn't habituate, we were missing something in therapy. It just wasn't working. They weren't putting in enough effort or time, maybe, or whatever it might have been. And now we recognize, hey, if you've learned a new way to respond, but something still bugs you, but this new way of responding is working for you, great. I think that's huge improvement in people's lives.
Absolutely. But I have to tell you, as somebody who went through treatment in the age of habituation and being a therapist, there are times where I help people using the inhibitory learning response without doing habituation. And I kind of feel, I feel some sort of way about that.
Yeah. I bet. Bruce also says, can OCD seems to create a calendar of events that need to be followed in order. Yes, absolutely. So you have to do this, then that, and it must be done in this way. That's why one of the things that we'll do for ERP at times is to maybe make flashcards that have all of the different things that you do in a certain order, and then we mix them up, and then you got to do it whatever the mixed up way is instead of the way that OCD wants it done. You can still do all the things. You're just not going to do them the way OCD wants them done. And then eventually we might remove one of the flashcards and say,
You mean you don't do them in the right order?
I know, it's a shocker, isn't it? Yes, right? You might have to brush your teeth before you comb your hair instead of the other way around. And OCD, of course, says, oh, there's only one way to do it.
Yes, and loudly.
Yes. And I'll bet when you were trying to break some OCD habits, it did yell at you a few times.
Oh, yeah. And that was one of my things. It's like, this will be done in this order, in this way, in this sequence. And sometimes that sequence took me an hour and a half. And if I broke sequence, I go back and start again. Mm-hmm. That really messes with your sleep.
Yeah. Mm-hmm. Yes. Mm-hmm.
But the nice thing about it now is I don't care. Like, you can interrupt anything in my life, in my routine. And usually it's something now that I enjoy, because if something in my life doesn't fit into routine, it's because I have company over, I'm going out with friends, I'm living a life. And so now a break in my routine is not something distressing. It's usually something enjoyable.
Did you get permission to live your life, or did you just decide to do that? I'm just curious.
Kicking and screaming through therapy, I decided.
There you go. There you go.
Yes.
Here's one for you, Stacey, that I think is going to be really interesting. Quentin says, so nice to see this topic being addressed. The substance I have a problematic relationship is with caffeine. I habitually go past the recommended daily limit. Have you seen anyone need treatment for that? And yes, I know it probably makes my OCD, BFRBs, and tics worse, but it's hard to stop anyway. What can you tell us about caffeine, Stacey?
Well, I mean, caffeine's a stimulant, and as I'm very fond of saying, legal does not mean safe.
You have said that a few times in some of
a few
things.
Yeah. Alcohol is legal, but for some people, it is not a safe substance. They go too far with it. In some areas, marijuana is legal. It doesn't mean that it's safe for everybody. Some people have some very negative effects of marijuana. I'm not anti-marijuana. I'm not anti-alcohol. I always tell people you've got to look at things for you and how it works for you. But caffeine is a stimulant. And when we take too much of it, it can have a negative effect. I actually own a t-shirt that says, I'm not addicted to caffeine. I just drink it to keep away the headaches.
There you go.
So, but it can have a negative effect. I mean, caffeine can lead to, as the person said, an increase in tics and compulsive behavior. It can make OCD worse. It can impact our sleep. And anytime our sleep is impacted, our mental health is impacted. That doesn't matter if it's OCD, PTSD, major depressive SUD. Sleep is a massive restorative function for our body. And if we're not getting enough sleep, then everything else is going to be thrown off. In the substance use disorder world, we have an acronym: hungry, angry, lonely, and tired. So if we're not eating right, if we get angry and we're carrying those resentments, if we're not socializing, we're isolating, or if we're not getting good sleep, then tired, we are at higher risk for relapse. And so caffeine can throw off your sleep cycle. It can increase tics. It can actually cause tremor in some individuals. And so, you might not want to cut it out entirely, but taking a step back from it. Now, as for treatment, there's really not a medication anybody can give you. You can talk to, a therapist about, some behavior modifications, some lifestyle changes. But just like everything else, this is almost a response prevention. Like when you're trying to stop, let's say, an illegal drug like cocaine, the way to do that is one day at a time, not take that drug until it becomes more of a behavioral pattern. So sometimes you try to cut down, like with caffeine. And so you take a step back, maybe one less caffeinated item per day. And if you're drinking anything with like lots of caffeine, like a Red Bull, take a step back to coffee, because you're going to have to wean off of it. Your body's gotten used to it, and there will be a withdrawal process. And usually that is a whopping headache.
Yeah, because your blood vessels respond to caffeine.
Yes.
And then when you stop it, your blood vessels switch, and that change in the blood pressure in your head is what leads to the headache.
Yeah. So it's just a case of slowly taking a step back, but you'll find a lot of things can reset and you'll see small improvements over time. But you don't want to go cold turkey because you will get a massive headache.
Yeah.
And it hurts.
Oh, they do. Yeah.
Yeah.
Joe says, my OCD and mental health in general tries to tell me that I can't go back to work and to my hobbies until I stop the compulsions, full stop. I feel like this is a lie and that actually going back to work and my hobbies will, in fact, be therapy, even if I still have compulsions initially. I agree 100%. Go back to doing them and work with whoever you're working with on recognizing when the compulsions are trying to come in. do specific ERP around those, and get back to living the life that you want to live and not the life that OCD wants you to live. OCD wants you to be stuck and to not go back to work and to not do anything, because then you could devote more time to OCD. OCD is very selfish about your time.
Oh, yeah. More.
I think this is going to be a fun one for you, Stacey. Everywhere I go, I see my triggers. It's been 370 days, and I can't go a day without seeing a trigger. Do you still see triggers every single day of your life, Stacey?
Besides the fact that I'm legally blind and the term "see" is a little funny. No, right. I don't see my triggers at all, you know?
Yeah, I'll give you that one. Yeah.
But yeah, no, life is full of triggers, and I do. I remember I was sitting with you at lunch, and I was having a bacon cheeseburger, and a piece of bacon fell like onto the table, and you're like, "Are you going to eat that?" And I thought, "Hell no!" And you told me you're not allowed to not eat bacon.
Yeah, right. So you ate it then.
Yeah. I did. You know, but in my head, I was like, "No, it touched the table. Ew." You know. So they can pop up at different times. You know, I was in a pharmacy once just going to pick up my medication, and the person in front of me threw up all over the place. I was like, oh, hell no. I ran out, and then I was like, no, you can't do that. I went back in and got my but you never know when something's going to pop up.
Yeah. So I would never want to create a scenario where the goal is that I won't experience a trigger. I would want the goal to be, I'm going to be triggered all the time, and I'm going to handle it in such a way that I'm not going to give in to what OCD wants me to do when I experience a trigger. Because for free the mind here, it would also be like, I'll only be okay if I never think about X, Y, or Z. Well, you just screwed yourself there with that, right? It's not about not thinking about something. It's about knowing that I can handle thinking about something.
Yes. And that you can handle the triggers. They will show up. You know, but that, you know, keeping on our theme, it was very interesting to me because when you were treating both OCD and SUD, you had the virtual reality machine where people were like, oh, I could totally handle being around alcohol. And then they'd see alcohol in this virtual reality machine and they're like, never mind, you know, I need more treatment. But the whole goal was to get them to the point where they could handle the trigger and not give in to the behavior. And that's the goal of OCD treatment as well, is you can sit with uncertainty, you can handle the trigger, and you can respond in a different way.
Do you do any work with process addictions at all, Stacey?
Not a lot. I have, but right now I don't have a lot of people because I'm so focused on co-occurring OCD disorders.
Yeah.
You know, and a lot of that for me right now is OCD and SUD and OCD and PTSD. Because most of my work is with the VA. So that's where a lot of it lies.
There was a question about sex addiction and how it almost mimics OCD obsessions and compulsions. I mean,
yeah, but so does any addiction, and whether it's, you know, a process addiction or a substance, because you spend far too much of your day thinking about it, either trying to avoid it or engage in it and think about it or think about not doing it. And, you know, that's your whole life is around the addiction, whether it's a process addiction, sex addiction, gambling, or a substance. It very much mimics the obsessive thinking. Like when I was using, I woke up and my first thought was, I got to pee. My second thought was, I need drugs. And that kind of did my whole day. And it was the one thing that also quieted my mind. So I sought after it. But if you think about, you know, 16 hours in a day, and I was either thinking of using, or drugs, or how I was going to get money to get drugs, it just it becomes this cycle that you go on. And when you don't have them, you think about them. And when you do have them, it's like a compulsion. It gives you short-term relief, but then it comes back and the obsession comes back and you go into withdrawal. And so you get up and you do it again the next day and the next day and the next day. So they very much mimic each other in the thought process and in the behavior.
Yeah.
Addiction is a compulsive behavior.
Absolutely. After facing intrusive thoughts, what's the best thing to do? Avoid doing compulsions, or to respond to something like maybe, maybe not, or both? You can do one, other, both. It just kind of depends. So ultimately, you don't want to do a compulsion, because compulsions feed OCD, and OCD eats compulsions for breakfast, lunch, and dinner. And you want to learn how to handle being with doubt and uncertainty. So a phrase like maybe, maybe not, or something along those lines can do it. I may or may not have a heart attack by the end of this webinar. It is a possibility, right? And I'm not going to do any compulsion to try to prevent it from happening. So I'm just going to allow that to be there and see what happens. Oh, Carolina, any advice on the compulsion to try and solve OCD? Well, I'll throw a little bit in, but I'll get our lived experience friend to speak a little bit on that one too. But let me say this. No one has solved OCD as of yet. No one will solve OCD, because no one with OCD would have the answer anyway, because OCD is the doubting disorder, and it will doubt every answer that you give it, and therefore you won't be able to give it an answer that it will fully accept. And therefore, yes, this is a compulsion to try to solve OCD. So maybe one of the things to do is, instead of giving into the compulsion, recognizing it as a compulsion and saying, oh, all right, I know that I'm not going down that rabbit hole. I'm going to go and move on and live my life, right? Because that's not where we want to go. But it is probably, and Stacey, I'll let you speak on this, I'm sure it's amazingly alluring to try to solve the OCD and come up with an answer that will just give you everything that you've ever wanted. Yeah.
I'll let you know when I do. I mean, let's face it. I'm an individual with OCD who went to school to learn how to treat OCD, and I still don't have the answer.
Yeah.
Because it from an OCD perspective, you can't solve it. You learn to sit with uncertainty.
Mm-hmm.
There, you cannot solve for X in OCD. Sorry.
Yeah. It's just not going to happen, right?
No.
And go ahead.
I was going to say it's not going to happen because there's no answer OCD will accept.
Right.
That's the trap.
Yeah. And even if today you felt like you solved OCD, guess what would happen tomorrow when you wake up tomorrow?
It will say, "Are you sure? Let's go over this again."
Yeah, just maybe one more time, right? Yeah. Maybe one more time. Yeah. Emma asked something that I think will be really helpful here. How do you deal with a marijuana detox and withdrawal symptoms while OCD symptoms increase in your detox?
Yes, because detox does increase your stress. And as I said earlier, when your stress goes up, your OCD symptoms can also go up. And I think what you need to do there is be very focused in on your self-care and give yourself some self-compassion. Because the work we do in therapy for ourselves to improve our lives from OCD, SUD, and other things takes time, energy, and effort. And I think one of the things that trips a lot of people up is they forget this is a journey and it is hard. And give yourself some compassion, make sure you have time, make sure that you're talking to your supports and that you're honest with your supports. Because if you're not honest with the people who are there to help you, then you're not going to get the support that you need. Sometimes we like to say, oh, I got this, I'm strong, I got accused. This was just a statement. I am not a veteran. But one of my psychiatrists once said, why do you have to try to be such a Marine? And I was like, I don't know, but self-compassion and allowing yourself to have the space and the time to do this is important. And also not giving into the compulsions while you're going through the detox. It's hard, but the problem with giving into the compulsions is it teaches yourself that you have to give in order to not use the substance. And you don't have to give into the compulsion, and you don't have to give into the craving for the substance. But I'm not saying it's easy. Treatment is probably one of the hardest things you will do, but I wouldn't give back the life I have today for anything. And it was worth every ounce of, struggle through the process of ERP and habituation. I hated it. I hated the process, but I trusted the process. I had built up enough credits sort of in therapy by the time I got to ERP that I was like, okay, this might suck, but I trusted the process. And recovery is fantastic. I've never met anybody in recovery who wants to give it back.
Yeah, right.
Mm-hmm.
And now looking back at it, your hatred of having to go through, the treatment, what do you hate more, the treatment or the OCD?
Oh, the OCD.
I figured. I wanted to be sure that everyone fully understood that part of it. Yeah.
Yeah. Mm-hmm. But treatment's hard. And I use this example a lot. And, I know you kind of get this one. Doesn't always have the best outcome, but if you have some other type of disease like cancer, the treatment's hard, and you do it because you want the chance. And so when you go to therapy and people ask you to do hard things, if you want the chance at recovery, jump in. Does it suck? Absolutely. But we have a great chance to get our lives back and to have the lives that we want. But, you've got to go through it. And in this aspect, the outcome tends to be better, but with anything, like if you develop diabetes and you have to use insulin, nobody likes that. Nobody wants that, but we do it. I think sometimes in mental health, we're like, I don't want to. But if you do, the chances of you getting a better life, a healthier life, go up exponentially. But when it comes to medical issues, we'll totally agree, oh, you broke your leg, I have to put 14 screws in it. You're like, okay, do the surgery, doctor. You got to go to physical therapy after you get the cast off. Okay, I'll do it. In mental health, we're like, I don't want to. And sometimes if you want to get to the recovery, you have to engage in the treatment.
Yeah. Does ERP work for fear, rumination only, intrusive thoughts, OCD? Well, no, it also works for images and urges as well. I mean, I've treated plenty of people who had urges that they felt were terrible to have, or images they felt were terrible to have, and it worked equally well for those. So it is not just about thoughts. Sometimes people use the thought term as like a collective of everything, and then people who have urge or image issues then feel left out and think, oh, well, OCD is just thoughts. It's not images and urges. That must be something different. And we just want to clear up that it is not something different. And that's why when I do talks, I always try to mention thoughts, images, and urges as much as I can, just so that it doesn't feel like it's just thoughts.
And sometimes it can be all three.
Yeah. Jenny says, I'm confused if I have pure fear or is it OCD? Well, that sounds like something OCD would love to throw at someone to get someone off the trail of OCD, doesn't it, Stacey?
Uh-huh.
Yeah. Okay. Here's the thing. Does it really matter? Because I'm going to bet you this ERP is going to work no matter what.
No matter what. Yep.
Mm-hmm. So I would go down the ERP route anyway. Are unstoppable thoughts a sign of OCD? Ooh, boy, I got to think about how I want to answer that. Because on one hand, I don't know what an unstoppable thought is, and I also wouldn't want to give anyone advice that we can stop a thought. How about this? You may have thoughts that keep occurring a lot and wish that they didn't. Is that a sign of OCD? It could be, right? It could very well be. It is a possibility, probably a strong possibility. And what I would do is I would take that to someone to get an evaluation to see if that's actually the case. And then if so, using good ERP to help you with that. Caven Beaker says, is me rethinking they all feel normal, I guess. Well, definitely rethinking something can be a compulsion.
Can you reread that question? Because for me, you froze.
Oh, did I freeze for a second? My apologies. Is me rethinking a situation between me and someone I care about a compulsion? Sometimes I don't even know what to think, what is a compulsion or not, because they all feel normal. Stacey, I will bet this happened to you. There were times you had conversations with people and then played them over and over for hours in your head, wondering if you said something the right way or if they said this. And maybe if you had said this, then they would have said that. And then it would have turned out different and blah, 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 blah.
Can I plead the fifth? I don't want to incriminate myself, but
yeah.
To be honest with you, if I had $1 for every hour I did that, I could probably retire tomorrow.
Yeah. Mm-hmm.
And I still do it now, but not as much. We question things, but when it's OCD related, it just goes on for hours. I would have the same rehash of a conversation for weeks.
Mm-hmm.
Talk about being stuck.
Seriously. Yeah. I have even seen it where people are still in the parking lot for hours after their session, standing by their car, wondering, should I go back in and just ask one more question or just get one more clarification or just say, hey, did you really mean this when you said that or that? Every one of those is a rabbit hole that OCD would love to go down to try to get you to keep doing compulsions. For sure.
And you're frozen again. Uh-oh.
Nope. You froze a little bit today, too. Who knows? The interwebs are having a tough day today. Maybe that's
yes.
Mm-hmm.
They are messing with you.
Yeah. Any advice for dealing with OCD around relationships, trusting yourself and your decisions? Even without OCD, relationships are difficult. I just want to throw that out there. Number one, right? And because of that, it isn't going to be about having a great relationship. Sorry for the not so great Wi-Fi, everyone, tonight. I'm not in my usual place, so it may not be as good as it normally is. But in relationship OCD, there's always a couple of issues, right? Are we good enough? Are they good enough? Do we love each other enough? Are we attracted to each other enough? It would be very hard to be able to come to a definitive decision on anything when you have OCD, much less a relationship. Welcome back, Stacey. Good to see you again.
Yeah, I got booted. What up?
I didn't do it. It wasn't me. I just would like you to know that was not me.
Sure. Okay, you stick to that story.
They were asking some advice around relationship OCD and trusting yourself and your decisions. And I was saying, you don't have to have OCD to not feel great about a relationship, right? You can still have doubts and insecurities and wonder about if you've made the right choice, even without OCD. So that is a possibility.
Yes. 50% of marriages in the United States end in divorce.
Yeah. So.
So.
Mhm. Yeah.
50% of the people do not have OCD.
Right. Mm-hmm. I'm just kind of checking out a couple of things here. Yep. Um, Relationship OCD has come up a few times here. Also, a belief that a boyfriend has it. I'm glad he has an appointment with a therapist. He's still in denial. That could be. Yeah. Uh-huh. All right. Ooh, here's a good one, Stacey. I'd love your opinion on this. ADHD and OCD. How do you do it without medication? I mean, what have you seen on that one? Because some of the stimulant meds can be difficult, obviously, for some folks, but there are also non-stimulant medications that can be helpful for ADHD that then wouldn't have some kind of impact on OCD also.
Yes. And not a medical provider, not a
Nope.
psychiatrist.
Neither of us are, so we take that as part of this. Yeah.
Right.
Mhm.
But there are some non-stimulant meds that can be helpful for ADHD. So that's an option. And again, you can actually engage in behavioral treatment for both OCD with ERP, and some aspects of ADHD can respond to cognitive behavioral therapy if you understand the different aspects of the executive dysfunction and you develop routines that are beneficial. Sometimes it's understanding how your ADHD presents and where your stuck points are. If it's an initiation problem, then setting a schedule, a routine can be helpful. If it's a follow through or a motivation problem, setting limits to how long you engage in a particular activity, like work for 30 minutes, take a 5-minute break, stretch, come back, work for 30 minutes. So some of that can respond to types of behavioral interventions. If you put the two together, medication and the therapy, you can make really good progress. But anytime you're dealing with a co-occurring disorder, you want to make sure that you're working with a professional and that you're availing yourself of all of the options. I often will recommend to people with co-occurring disorders that you do get with a psychiatrist or someone who can prescribe medications that knows about OCD, because that prescribing is a little different than other mental health conditions. And you want to make sure that you're getting the right medication at the right doses to be beneficial. And then also engage in the behavioral aspects of it. And you might need to have one therapist for OCD and maybe one that understands the ADHD a little bit better, or, and make sure those two people are talking to each other as well. I work with a lot of individuals who see somebody for their SUD and then they see me for their OCD, and we sign releases so we can talk to each other and give that person the most integrative treatment, so we're not telling them different things. But when you have a co-occurring disorder, you want to really consider the benefits of a combination of medication and behavioral therapy.
Yeah. And those releases are important to make sure that providers are all speaking to each other. That's really a key experience.
Actually, the best treatment you can have is when people talk behind your back. I know it seems weird because we don't ever want to talk, but when medical providers are talking behind your back, you are going to get the best treatment. You want them, the treatment teams, if you're, in a residential, you want them to talking to each other. If you're in an IOP, you want them talking behind your back. And if you're working with two different types of providers, a psychiatrist and a therapist, sign those releases, let them talk behind your back. It's the best treatment you will ever get. Your friends doing that, but you do have your providers doing that.
Right. There were some questions too about fear around developing other conditions, like what if I will develop psychosis or schizophrenia or some other type of thing. And I often wonder about OCD using something like that almost in a distraction mode. If OCD can get you to think about developing something else, then you're not going to worry about having OCD, right? And then you're going to feed OCD by doing all these compulsions to try to see if you have this other condition. And you're never going to be fully convinced if you do or don't have the other condition. And you're going to keep feeding the OCD by trying to figure it out. And OCD just really wins really, really well in that situation.
Mm-hmm.
Yeah.
What if?
Oh, that phrase.
Yes.
I'll tell you. It is the underlying issue of life is that phrase, right?
Yes.
Mm-hmm.
My two favorite OCD phrases: "What if?" and "Are you sure?"
Are you sure? Yeah.
Yeah.
I also like "What If's cousin," which is "Yeah, but what if?"
Yeah.
Because the moment somebody asks me a "what if" question and I give them some kind of logical answer, they will follow it up with "Yeah, but what if?" and
What
then
if? Yeah.
go to
Yeah,
the
but
next.
what?
Yeah, but what if
Okay.
this?
Yeah, but what if? Yeah.
Okay, yeah, but then what if this? Well, how about that? Yeah, but what if this? So I don't do that anymore. I've given up on that because, as you and I both know, never once have we given an answer to someone with OCD that they've said, "Oh yeah, great, that's awesome, thank you, I'm cured, no problem anymore. Really appreciate it."
Yep.
It just does not work that way whatsoever.
No.
Yeah. I do apologize for everybody for some of our spottiness in in our webinar tonight. Seems both of us are having a little bit of a internet issue, but that's okay.
Yes, we're dealing with the uncertainty of our internet.
Yes, absolutely. And how do we deal with some of this if we can't necessarily afford a psychiatrist and therapist? Um, I wish we all could. That would be wonderful. And B, you might have to work with one person at a time, but take really great notes, right? And get really good advice from that, and then move on to the next thing. And then maybe you work with a therapist who can help integrate both of those things. That there could be possibilities that way. Some places might offer groups, and groups can be a cheap alternative, maybe to some individual therapy. So maybe you have one person who does things individually or for med management, and then you also attend a group. There could be options out there like that. And some groups are even free, like the goals groups that the International OCD Foundation has a listing of through their website on iocdf.org. So you might want to look into those.
Mm-hmm. And for OCD, there are a number of self-help books and some resources. There's also some lower cost peer support specialists for OCD, like Shannon Shai. He has a book. He has some flashcards. He actually does some things on YouTube, to share some of his insights about his recovery. So that's an option. And there are also a lot more platforms that take insurance as well, such as like NOCD is a platform that does specific for OCD treatment. There are platforms that do provide psychiatrists that also take insurance. So there are more options today than there were, say, in 2017 or 18. So a little exploration can be helpful, but sometimes you do have to look for those free resources as well.
Yeah. Any other things that you wanted to add? There's a lot. I love it. There's a lot of chat going on between everybody. So that's what's really cool, and everybody's being very supportive of everyone.
And people are asking, yes, it's Shannon Shy. He is a peer support specialist. He has OCD. He's a former Marine. So my veterans really like hearing his perspective. But he has a few books out. One, I believe one's called Turning Points. And that is his most recent. He's also on YouTube. So if you put in Shannon Shy OCD on YouTube, you'll be able to find him. And then he shares the resources that he has.
Yeah.
And some of it is free and some of it is paid. But there's a lot of good information out there. There's also other self-help books in terms of, that really reputable people have written. So if you're having trouble, affording therapy, it's an option. It's not the best option, but at least you can learn a little bit and educate yourself. So when you get an opportunity to engage with a therapist, you have some of the information already, running around your head. You can use your time effectively.
Mm-hmm.
It's always best to work with a professional, but I understand if you can't afford it. These are some things that I'm throwing out there, and Patrick said a few things that can at least start you on this road.
Right. Absolutely. And good to see that, again, everybody's just really being so helpful on the chat. Any tips on how to manage rumination for contamination during the OCD cold flu season? Well, you might get a cold. You might get the flu. So we all live with that as a possibility. And thinking about it is not going to change your odds. And sometimes doing compulsions actually increases your odds of getting something, because the more that you wash your hands, let's say, the more you wash the oils off your hands, the more your hands have a chance to dry out and crack and peel, which leads to more transmission sites for germs, which means you will now want to wash your hands more because you have cracked and peeling hands, and germs can actually make it easier into your body than anything else. So maybe doing the opposite of what OCD wants you to do actually would be the most helpful thing for your issues with contamination that you could possibly do. Just an idea there, right? Now, I can't guarantee that you will or won't get a cold. I might get one tonight. I don't know. It is possible. What would be the worst case scenario? A horrible flu and I would die. That would be the worst case scenario. And although for some people that might not be a worst case scenario, they might be like, "Oh, good, we're done with them. We don't have to deal with them anymore." So some people might love that. I don't, but I could, as I've said before, I could live the rest of my life sitting next to my tombstone, wondering when I'm going to be under it, or I could live the rest of my life and have a great time, showing up on the day of my death, saying, "Well, that was fun," and then be under my tombstone. We're all going to end up underneath it at some point. What we do in the meantime is what to me is the most important thing. And I refuse to live the rest of my life just worrying about when it's going to happen or how it's going to happen.
Yes, it's not about dying. Everybody dies. It's about the stories they get to tell about your life when you're done.
Right. Yeah. So if, Stacey, boy, what can I say about her? Boy, did she worry a lot, and just worried about when this day was going to come. She spent the last 20 years of her life sitting in that easy chair thinking no one should ever enter her home so that there would never be any germs, only eating canned goods that were delivered to her home that she let sit outside for at least 2 weeks to make sure that any germ that was on them from the person who delivered them would have died. And here the day has finally arrived. So, and that's what I can say about Stacey, right? Well, that sounds like crap, doesn't it? I mean, boy,
Yeah.
who wants that, right?
Yeah. Yeah.
Nobody wants that. So that's what we hope you don't do with your life, is that we want you to live your life and not the OCD life. OCD wants you to live the OCD life. And you know what? Even like here, there's some discussion about driving and fears around driving. I may run someone over the next time I drive. I may get killed in a car accident the next time I drive. Again, I don't know. And I also don't know if I'll walk up and down a flight of stairs next and fall or not fall. So, you know, I know nothing. The house I'm in could get hit by a meteor. There could be a natural gas explosion. It is possible that me not driving doesn't matter because a car loses control and rams through the house that I'm in, killing me and everybody in it. I mean, there's just so many ways that I could go from this world. Why? I mean, if you're going to worry about one, I say worry about them all. I mean, right? I mean, why not? Just if why is one more important than the other, right? Why would this be the worst way to go, but all the other ones are fine? Why is it okay to die by falling down the stairs, but not okay to die while driving? I don't know, right? But OCD seems to think that there is a difference, and one would be better or worse than the other. So. Stacey, any other things? I think I'm going to wrap up a little early just because we keep popping in and out here. So I don't want people to have to worry too much more about us popping on and off of this. But any things you want to add for the end here before we jump?
Well, we're in the midst of the holidays, and I think I would just tell people, feel free to take a step back. Don't feel, pressure to meet everybody's expectations around the holidays. It's okay to go slow, to take breaks, and to have a little self-compassion around this time of year. You don't have to show up to every Christmas party or every, Hanukkah lighting or whatever holiday, the ones you want to go to, great. The ones if you need to take a step back, take a step back, because as we've said a lot tonight, stress increases symptoms of OCD, of SUD, of PTSD, of depression. So cut yourself some slack. Realize the only expectations you have to live up to are yours.
But please don't avoid something because OCD says it's a great idea. That we would ask you not to do.
Yeah, that you don't want to do. But I find a lot of people feel an incredible obligation to do things at the holidays, and they stress themselves out. It's a huge time for relapse, particularly with those with substance use disorders.
Yeah. So all the best to all of you from me and Stacey for this. And thanks for sticking with us through 2024. And we'll be back in 2025 to
see you next year. How to say it.
So we'll see you next year. All right, everyone. Make it a great night. We'll talk to you later.